Hi, this is Brian Kim. I'm going to share with you this easy technique to reverse optic capture an MA60AC or any three-piece IOL actually for prophylaxis of negative dysphotopsia. So again, negative dysphotopsia is when there's basically a space that's created between the pupil plane and the lens plane. Remember, the natural lens is thick and fat like a UFO, and so it has three-dimensionality. It hugs the pupil. And when you take the cataract out, the lens implant is very thin, has a thin profile, and therefore there is a space that's created between the pupil plane and the lens plane. And so in order to deal with negative dysphotopsia, you want to bring that lens up towards the pupillar plane to reduce that potential shadow that's cast off the edge of the lens. So I use a corneal marker to help me center and size the rhexis, and then I'm using a cotton tip to steady the eye. And then I make a paracentesis incision first on the right side and then the left side, making sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready, I enter. So you get a nice little shelf there. So these are the Haldane-Parker forceps. I puncture the center, pull downward, creating a tear, grabbing the right side of the tear to create a flap, making sure the tear is the appropriate size for my rhexis. Again, using the mark to help guide me to get a nice size and centration of the rhexis. Again, very good control, minimal viscoelastic egress. Burp the viscoelastic out. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, freeing up the anterior capsule on both sides, and then gently turning the lens. Hooking the peripheral lens, and you can see the lens spins now. Irrigating the surface of the cornea, adjusting my sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, crushing and bisecting the lens in half. That's double chop. With the phaco tip in the same place, I just go ahead and place the chopper under the rhexis edge under the right side and crushing the right heminucleus in half. That's cross chop. Using some vacuum as well as a chopper to bring that first quadrant up, crushing the lens into smaller pieces and then emulsifying the lens piece. Again, doing the same maneuver, placing the chopper around the second quadrant and then crushing, dividing the lens piece into smaller pieces and emulsifying the lens piece. Grabbing that remnant with a little bit of vacuum and then crushing it in smaller pieces and emulsifying the lens piece. Rotating the second heminucleus in front of me. Placing the chopper under the rhexis edge, pulling it centrally toward the phaco tip, bisecting the lens, using some vacuum to lift that third quadrant, crushing the pieces between the instruments, and then emulsifying the lens pieces using sparing amounts of ultrasonic energy. This is the last quadrant, placing the chopper around the lens, crushing the lens between the instruments. That didn't quite work. Let me try again, placing the chopper around the lens, and then crushing it there. The reason why it didn't work is because sometimes the lens slips and the chopper doesn't get around it completely. And so you just have to go back and do it again. It's not a big deal. Crushing the lens between the instruments again here, very carefully doing that, again, without using ultrasonic energy or vacuum. Again, this is a very controlled situation because I'm using mechanical forces to crush the lens piece in the central safe zone. Again, minimal risk for complications doing it this way. So the endonucleus removed using the vacuum to remove the epinucleus here, placing the chopper deep in the bag to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, start to remove the cortical material. There's a little bit of cortical material on the right side there, but really otherwise there's not that much. There's some wispy stuff in the bag here, so I'll have to try to go after that. Switch to polish mode, polishing under the rhexis edge. And I'm going after that wispy stuff as well. Anytime I grab the cortex, I switch to cortex mode and remove it there. Pulsing BSS into the subincisional capsular fornix there. You can see there's some stuff coming out, grabbing it with the INA tip. Again, some fine wispy stuff. When you don't have a thick layer of cortex after you remove the epinucleus, I've noticed that, at least for me, it tend to have these fine wispy stuff. So you just have to make sure you go after it. It takes a little bit of time. Go ahead and push some viscoelastic to fill the capsular bag, cohesive viscoelastic, and then I'm polishing under the rhexis edge with the sweep, first on the left side and then now on the right side. And this is the Singer Coke sweeper. The angle and the thickness, and it's again a sharper edge to it. It's just a better one, better than the first generation. So we'll widen the incision. Again, this is going to be a 3-piece lens, and we're going to do that reverse optic capture technique, like I said. Reverse optic capture techniques means the haptics are going to be in the bag, but I'm going to pop the optic up anterior to the capsulotomy opening. And because the capsulotomy opening is smaller than the optic diameter, it captures the optic up. And a cat-eye configuration is essentially a buttonhole technique. So I get underneath the lens, removing the viscoelastic. Polishing under the rhexis edge. You want to make sure the bag is completely clean at this point. First, I'm removing the viscoelastic from the anterior chamber. So remember, you just want to remove all the viscoelastic before you do the reverse optic capture, because you don't want to go after viscoelastic afterward and you might end up undoing the reverse optic capture. So you see I made another incision for these micro forceps. I'm underneath the lens with the INA handpiece, which means the optic is anterior on the proximal side, and then I use that forceps to lift that distal side of the optic up. And so by doing this two-handed technique, I was able to get a beautiful reverse optic capture. Again, you can see the almond configuration of the capsulotomy. This tells you that the optic is anterior. Again, I got underneath the lens with the INA, so the proximal side, the optic is above. And then using microforceps on the other side, I was able to make sure I pushed down on the capsule, making sure the optic popped up. And then with the two-handed technique, gently coming out and maintaining that position. And because I had a smaller size capsulotomy, it was able to grab and maintain the reverse optic capture configuration. The optic didn't pop back down as I was doing the maneuvers. And that's another reason why you remove all the viscoelastic first before you try to attempt reverse optic capture. Because if you start trying to remove viscoelastic and do all this stuff, and the irrigation pressure might cause the optic to pop back into the bag, and you have to start all over. And so again, I have a nice reverse optic capture configuration, and this is my two-handed technique on being able to achieve the reverse optic capture configuration very easily with the 3-piece lens, and the patient did well. So I hope this was helpful to you, and I thank you for your attention.